Approximately 60% of the total body weight in an adult is water. Fluid in the body is located inside and outside the cell. 2/3 of body fluids are intracellular, or ICF, and constitute 30 to 40% of body weight. The ICF provides the cell with a balanced environment to conduct life-sustaining intracellular metabolic activities. The remaining 1/3 of fluid can be found in the extracellular space. The extracellular space is further divided into the vascular bed, which houses the plasma, and the interstitial space, which accounts for 15% of body weight. Plasma accounts for 4% of body weight. Lymphatic fluid, cerebrospinal fluid, and synovial fluid are also considered extracellular fluid, or ECF. The substances found in the fluid of the vascular bed, such as electrolytes and glucose, are very similar in those in the interstitial space. However, the vascular bed contains more protein. ECF serves as a transport service for the body's cells, moving vital nutrients to the cell and carrying away waste products. The fluid status of the extracellular fluid compartment and the intracellular fluid compartment is normally very stable. Losses of ECF do not typically require rescue from the fluid component inside the cell. These losses are referred to as isotonic volume losses. Compensation for loss is usually achieved by fluid movement between the intravascular and interstitial space. Severe extracellular fluid losses can cause a shift of the fluid from the intracellular space to the extracellular space, thus threatening the survival of the cell. An extracellular volume deficit is a deficit of water in the intravascular and interstitial spaces. The pathophysiologic consequences of fluid volume deficit range from mild abnormalities to hypovolemic shock and death. Some of the common causes of extracellular fluid volume deficit are fluid losses from the GI tract, inadequate fluid intake, renal losses, insensible losses, and third space losses. Certain circumstances and disease processes place the client at risk for the development of extracellular fluid volume deficits. When the mechanism is fluid losses from the GI tract, the most common risk factors are vomiting, diarrhea, nasogastric suction, and GI fistulas. When the mechanism is inadequate fluid intake, risk factors include an abnormal thirst mechanism, an inability to communicate thirst sensation, an inability to acquire fluids, immobility, and an inability to swallow. When the mechanism is increased renal losses, risk factors include diuretic therapy, osmotic diuresis, and Addison's disease, or hypoaldosteronism. When the mechanism is insensible losses, risk factors include fever, sweating, deep open wounds, and bleeding. When the mechanism is third space losses, risk factors include edema, ascites, bowel obstruction, peritonitis, and burn injury. The signs and symptoms of ECF volume deficit range from mild to severe. An early finding with vascular depletion is orthostatic hypotension with reflex tachycardia. The client might also report dizziness while in an upright position and have weak, thready pulses. As the deficit increases, the cardiac output becomes compromised and signs and symptoms of decreased cardiac output dominate the client's profile. Additional compensatory manifestations develop in response to the falling cardiac output. As the interstitial space becomes depleted, the client will report thirst, skin turgor will be poor, and mucous membranes will be dry. More signs, early, progressing to late, are weakness and fatigue, dizziness when upright, orthostatic hypotension, tachycardia, weak, thready pulses, thirst, dry mucous membranes, poor skin turgor, fever, slow peripheral vein filling, decreased urine output, soft and sunken eyeballs, hypotension, and shock. The presence of signs and symptoms in coexistence with risk factors provides the information necessary to diagnose an ECF volume deficit. Selected laboratory tests are helpful in supporting a diagnosis of the abnormality, indexing the severity, and evaluating treatment. An elevated BUN, serum protein, serum osmolality, hematocrit, or hemoglobin may indicate hemoconcentration of the vascular bed due to loss of plasma water. Urine-specific gravity and osmolality will be high because the urine is very concentrated. Urine sodium will be low because of the kidney's ability to conserve sodium and water in response to dehydration. The goal of treatment is replenishment of the ECF compartment. The underlying cause must be treated if the client is to return to and remain in a normal volemic state. Mild deficits can be treated with oral solutions that contain sodium. Moderate to severe deficits will require intravenous normal saline, that's 0.9% sodium chloride, initially until vital signs are stable. At that time, the client can be given half normal saline, that's 0.45%, which will rehydrate the cells and assist in the elimination of cellular waste products. Replacement of lost blood products may be necessary if blood loss contributed to the fluid deficit. A therapeutic response to therapy will be evident when urine output increases, hemoconcentrated lab values and vital signs return to normal, and signs and symptoms begin to subside. You can help prevent volume deficit by identifying high-risk clients and detecting signs and symptoms early. To prevent volume deficit, teach clients to consume fluids regularly. Offer fluids often to clients who cannot ask for them or who have inadequate thirst mechanisms. Make fluid conveniently available to clients who are immobile. Teach clients who exercise to hydrate themselves before, during, and after activity. Dietary consumption of carbohydrates and sodium is also important. Teach clients to avoid unsupervised over-the-counter laxative use and to notify their primary care provider if nausea, vomiting, or diarrhea last longer than 24 hours. Treat nausea, vomiting, diarrhea, and fever early and often. Perform and document thorough integumentary assessment. For hospitalized clients, monitor urine output, daily weight, and intake and output, and notify the provider of any variations from baseline. And monitor cardiovascular assessments so that changes in baseline assessment findings are recognized and treated early.